Lakshmi, can you call Vidya?
Ma'am, we are in
Yeah,
live,
I just
ma'am.
spoke to her. She's joining. She's joining. I
Okay.
think the first speaker can start
Himika. Yeah, yeah.
at least
Yes.
sharing, then the delay
Ma'am,
will.
we're in
Yeah.
live, ma'am. Please go
Yeah.
ahead.
Oh, a
Yeah,
very
shall
good
I?
evening
Good
to
evening. Shall I
one
share
and
my
all of
screen?
you. A very good evening to one and all of you for another interesting EYEEDU webinar from clinic to OR. So it's going to be some real world decisions in orbital infections and inflammations. And we look forward to making it so interesting that people would definitely go back, if not today, on some other day to watch it. Truly thankful to have with us Dr. Anusuya Gangli Kapoor, who's a consultant ocular oncology, ophthalmic plastic surgery, and facial aesthetics, who's also the head of the Venkata Chaudhary campus at LVPI Vijayawada. I think somebody has to call Lakshmi. Can you call Dr. Anusuya? She's not joined yet.
I've spoken to her. She'll join another. She'll be there. Yeah.
Yeah, and Vikas Menon also. We're truly lucky to have with us an eminent surgeon like Dr. Vikas Menon, who's a senior consultant at Arvind Eye Hospital in the Department of Ocular Oncology and Orbital Surgery and Glaucoma. We are very happy to have with us Dr. Lashmi Gupta, who's a veteran ophthalmic plastic surgeon who's all over Bangalore, there for everybody and anybody, and with her class surgical skills. And we have Dr. Tarjini Dave. We are truly glad to have you with us, Dr. Tarjini, who's again a senior consultant in ophthalmic plastic surgical services and associate director of LV Prasad Eye Institute, Hyderabad. Moderating with me are Dr. Vidya, who is a senior consultant oculoplasty and ocular oncology, who has been a huge asset for me all through my ARC days. And we are lucky to have with us, co-moderating with her is Dr. Lakshmi, who is with us as a consultant in our oculoplasty department. And she would be adding greater strengths to this eye education webinar. Without delay, we'll go on to our first speaker, Dr. Himika Gupta, who practices at the Apollo Group of Hospitals, Belapur in Mumbai. And she's going to take us. Oh, Vijay, are you the first speaker? I thought Dr. Himika was the first speaker. Dr. Vijay, you may go as the second speaker, I think. Dr. Himika, you have shared your screen. So
Yeah.
Dr. Himika would be talking on preseptal versus orbital cellulitis. Where do you draw the line? On to you.
Thank you very much, Chitra madam. And I would really like to thank you for including me in this teaching series. And this is a very nice and well chosen topic. And I was really amazed with the lineup, which is very exciting. So I have been given 6 minutes or so to decide where to draw the line between septal versus orbital cellulitis. So this is my line, and let's see where all we are going to put this line all through the presentation. These are my current attachments, and many of the patient pictures are from there. More or less, I practice in Bombay, in and around Navi Mumbai and Mumbai, and area of practice being orbit and ocular oncology. So, basics of anatomy, as you can see the first slide here. Anything, if we remember from the first few months of anatomy of orbit in our residency, we will recollect that there is a extraconal compartment and intraconal compartment. Okay, so the cone is made by the eyeball and the muscles around it, the four muscles, and then we have the subperiosteal space, and then we have these things called the orbital septum, which essentially goes from the tarsal plate and inserts onto the rim of the orbit. Okay? And they are a part of the eyelid, if I may say. So anything anterior to that is roughly orbit preseptal inflammations or cellulitis, and anything posterior to that is orbital cellulitis. Now, it's not always that simple. Like the Robbins textbook says, that the diseases do not read the textbooks when they come. So let's see what happens when they come to our clinic. Just two more slides on theory, and then we'll go through some case examples. So we all know that orbital cellulitis is a serious infection, and many of the patients are kids, often due to a uh, often due to a PNS infection or a sinus infection, which comes on to the orbit as a neighbor. And if there is chemosis, proptosis, or issues with the pupil or motility, then we have to be more careful because this is going into the sinister signs and maybe loss of vision or initially loss of just contrast sensitivity to when they look at the colored objects. Grave complications can be even life-threatening when there is cavernous sinus thrombosis or very bad subdural empyema extending into the brain. And we really need to look at clinical identification and stratify the risk and then manage. So this is the famous Chandler's classification of orbital complications or the level of orbital cellulitis, where stage 1 is simple preseptal cellulitis and stage 2 is orbital, where inside the orbit there is a problem, and stage 3, 4, 5 are the complications being subperiosteal abscess, orbital abscess, or something going into the brain, that is the cavernous sinus thrombosis. So let's go through some case examples just to understand, how something very mild as this photograph of this gentleman, which is a small sty, just like a small infection, versus the spectrum goes on to this full-blown orbital cellulitis with panophthalmitis. Again, coming to where to draw the line. So let us look at this is a very useful article by the Afte and Khalil's group. And if you can go through this, I really find it my to-go article each time I want to revise orbital cellulitis. But what we need to understand in our clinical practice is that if it is preseptal cellulitis or an orbital cellulitis without a complication, then we can go easy, as in we may or may not admit the patient. We will mostly not need the patient to undergo surgery. We will not need a very aggressive management. So this is where I drew my line. Okay. Anything beyond that, if a patient has a subperiosteal abscess, orbital abscess, obviously CNS complication, or any of the high risk features like blurring of vision, color issues, and ophthalmoplegia, proptosis, then we have to consider that it is more sinister and we have to be more aggressive in our management and plan to go in for surgery as and when needed. We'll be like on the we want to be on the top of things and we can't take it easy. Okay, so with that we'll just go through a few cases. This guy, I was called to evaluate this gentleman who was a 82-year-old, and they said from the ICU I got a call stating that they were suspecting mucormycosis. So if we careful, so he presented with inability to open eyes, and they said that he just can't, there's redness, pain, and he can't see, lot of swelling and photophobia. But if we carefully look at the pattern of lesions, there's a differential diagnosis like it could be herpes. And in fact, when we pried open the eyelids, everything inside the eyes was fine. This person also had chemo and was a immunocompromised gentleman. So this patient definitely, mucor or any kind of orbital infection was high on their differential list, but this turned out to be plain and simple herpes zoster ophthalmicus. And later, and this is just edema, and in fact, the edema, preseptal edema, spread to the other eye also, giving it a very scary look, but it was not orbital cellulitis. So, okay, my slides seem to be stuck. Fine. This is another child who presented with this lid lesion. But on scan, there was much more in the PNS as well as the lid. And when we finally biopsied, it turned out to be a eosinophilic granuloma. And here the location was purely preseptal. Now, this 4.5-year-old boy presented with a sudden onset, painful blind eye with orbital cellulitis, redness and pain, and blurry vision since 2 to 3 days. Even systemically, he had leukocytosis and looked very toxic. And his entire orbit was obviously inflamed. So he was a classic, orbital cellulitis with panophthalmitis and a white looking cornea. This guy actually turned out to be retinoblastoma with aseptic orbital cellulitis. So just to, again, going back to the same dictum that what we generally read in the textbook may not happen in real life. I think the last case, or maybe the second last case, this child, this infant, in fact, presented like this. Again, we got a call saying we feel it's mucor. The child is very, very toxic. He might go into septicemia any moment. Cultures came out negative. And this was actually a necrotizing fasciitis of the lid. The history was non-specific. This said that there were boils on the eyelid. And in fact, when we imaged him, if you can notice temporally also on the near the temporalis muscle also, there was a skin abscess which was going into the muscle. But again, the location over here, this cellulitis was pre as well as post septal. But on table, when we debrided him, the eye inside was totally intact, vision, eye, everything. In fact, we did a temporary maternal skin graft full thickness for him, and this child recovered beautifully finally. So he did not have orbital cellulitis, no matter how ghastly he was looking in on day one. The last case of the day was this driver who presented with a lower lid. First, it started as a lower lid boil, he said, and then it extended to such a level. Later on, with the chemosis, there was subconjunctival hemorrhage, lack of vision, loss of vision, vision drop, and loss of acuity, loss of motility also. He finally developed a orbital abscess, which was more in the near the inferior rectus. And after we did the treatment, basically steroids and surgery, he recovered very nicely. This is a nice flow chart, which is very useful, in the training period.
Doctor, 1 minute more.
Just last 2 slides, if that
Yeah,
is the
sure.
concern.
Yeah.
Okay. And basically, we have to understand that any child with orbital or periorbital infection, apart from ophthal, we have to involve ENT and pediatrics, or rather, we need to tell the general pediatrics or general medicine to involve us early on, because some of these cases we get involved slightly later because the child or adult is admitted under other specialty, and then picking up the signs, daily monitoring, and then prognosticating and taking a decision suffers. Exceptions to the rule include aseptic orbital cellulitis, like we saw a case of retinoblastoma, preseptal cellulitis, which was going much deeper than the septum, but still it was not orbital cellulitis, and some varied presentations like eosinophilic granuloma. To summarize, if the conjunctiva is clear and the pupils are reacting, then it is most likely preseptal cellulitis and not really involving orbit. If it is a gray zone, it's a good idea to admit, treat the patient like an orbital cellulitis case, and then watch. Obviously, imaging and steroids help, and our subsequent topics will cover that. Endoscopic debridement may be needed, but sometimes in current clinical scenario, at least in the in the circle that I practice, I feel that it is over pushed and it may not always be the answer to treat orbital cellulitis. An inability to open the eye may be just plain eyelid edema. So our most important tool is the Demar's retractor. Take it, try to pry the eye open, and just watch the pupils, conjunctiva, and ocular motility. Thank you so much for a patient listening.
Thank you so much for a wonderful talk. So crisp and clear with everything was there. Could you stop sharing your presentation?
thank
Okay,
you.
Mika? Wonderful it was. I think I'll take the first question with Dr. Rashmi. Now, something I'm going to start off with the basic as I let Vidya and others take on further. So what should a general or comprehensive ophthalmologist do? When should they image before they are going to refer it to your oculoplasty surgeon? What would you suggest?
Okay, so that was a very impressive set of cases, Himeka.
Yeah.
So one of the things that you mentioned is probably the crux of deciding between bacterial cellulitis versus others, CBC. So you see a patient with that kind of swelling, the first thing is a CBC, which comes in within a couple of hours, and start that off, and one more thing that most general ophthalmologists are scared of is the last point that Dr. Hemeka mentioned, is if there's lid edema, don't be scared to, pry open the eyelids and actually look at the eye. Very many times we can see that the globe is moving and the pupil is constricting. So if it is just that, possibly imaging is not necessary. But if there is limitation of movement, if there's proptosis, even before the pupil is affected, yes, definitely imaging would be necessary.
So on to you, Vidya. Unmute yourself.
That was a really nice presentation, Dr. Hemeka. It was very crisp and very nice, very all subtle points you have covered. Just a few diagnostic dilemmas. Like now we have borderline cases wherein we have a child with toxicity. Like patient may be having fever, may be having all clinical signs of going in for post-septal infection, but clinically it appears like a pre-septal infection. So how do you manage that? Whether you admit the child and treat as post-septal infection, or you observe and monitor the child? What do you do exactly for this? Maybe it will be helpful for general ophthalmologists and the other people who are working in a private clinic. That will be of more useful tip. Can you share something with us?
Yeah, that's a very relevant question in practice. So, a lot depends on the profile of the patient. If the patient is from the village and you know that he or she cannot follow up regularly, then you give them an option of getting admitted. In Mumbai, I also encourage patients to find a relative who is in Mumbai and just stay there, because you have to basically monitor the pupils and motility daily and watch for toxicity. So if the patient is not that toxic, then you may not admit. But more than 50% of these are kids. And then we are not sure, especially, and giving them just oral antibiotics may not help. So I would really tip more towards admission until and unless, there's an exceptional situation where that the patient or the parents will be very sincere with their follow-ups. And if they stay somewhere within the city, but at a different corner, they are getting a local IV antibiotic course, then you may skip admission. Or if, like, if you are in a pure private practice where you don't have a system to admit overnight, then you can even give them the option that go to your local doctor and get this IV antibiotic course and come to me regularly. So you have to really play by the ear. But given a choice, admission would be, the borderline cases. Yeah, we would rather admit, because you don't want to
Take
miss out
chance.
on the subtle signs and then, then feel that. And also, maybe after 48 hours, if all is well, you would like to start steroids. So, yeah, better to admit and keep them under close monitoring.
You're on the safer side than to feel sorry about. Okay. So, and also in children, we have to probably image them for subperiosteal abscess formation, or in case of progression. So can we just do it clinically, or you would go by CT scans, progressive CT scans, or what do you do? Like, given the chance of radiation and other stuff, so would you play more with clinical signs more, or you would give more importance to the radiology? What would you
Not a
practically do?
great fan of serial CT scans, but I think we have a talk on imaging, and
Yes,
we can
yes.
have
Yeah, next is that.
We can
the
cover it in
next
that.
week
Yeah,
go more
yeah,
in detail
yeah,
of that,
yeah.
but not a fan of serial CTs for sure, not for cellulitis. Yeah.
Thank you. Thank you very much for a wonderful talk which you've given. Second speaker has now yet to join. Vail Murugan, I would want you to please call her. And in the interim, I would request Dr. Vijay to come and take on, right? You would be talking earlier, Dr. Vijay. So I invite Dr. Vijay Rangarajan, who heads the Orbit Oculoplasty and Ocular Oncology Services at Arvind Eye Hospitals, Coimbatore, and a very warm welcome, Dr. Tarjini and Janusia. You all can switch on your monitor so that we can see you and actively involve you in all the discussions.
Sure.
Yeah. Hi. Hello. So, Tarjini, yes, connect. She's going
So
to be
I'm
talking on steroids and orbital infections and inflammations, friend or foe. So we are going a little out of sequence, but anyways.
ma'am, are you able to see my
Yes,
presentation?
Yes.
Okay, thank you, madam. So today I'll be speaking on steroids in orbital infection and inflammation, friend or foe. It's not moving.
Not moving? Yeah.
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 So orbital infections and inflammations are like a Pandora's box, and orbital infection and inflammations, they are not an exception. It's like an enigma to the treating ophthalmologist. So coming to the orbital types of orbital inflammations, so we can broadly divide them into infection, non-infectious, neoplastic, and others. So in infectious, we have bacterial, fungal, viral, and parasitic. Non-infectious, we have idiopathic thyroid eye disease, scleritis, sarcoidosis. Neoplastic, we have lymphomas and leukemias. And we have some other conditions like cerebral venous thrombosis and granulomatous inflammations. So coming to the history, first, always we have to check for the onset, the duration, the progression, associated pain, whether they have painful extraocular movements, whether loss of vision, trauma, or any history of surgery, systemic conditions like diabetes, immune status, sinusitis, thyroid eye disease, any drug intake. So coming to the clinical evaluation, again, as Himika had already said, visual acuity, visual fields, pupils, corneal sensation, exophthalmometry, thorough slit lamp examination, fundus examination, extraocular movements, lymphadenopathy, and any surrounding periocular adnexal involvement, and also orbital palpation is very important. So again, all this diagnostic testing like CBC, ESR, ANA screen, T-ANCA, P-ANCA to rule out any granulomatous inflammations, thyroid function test, MAN2, and imaging CT scan, MRI with contrast agents for fat suppression and X-ray chest. So coming to orbital cellulitis, she has already told just a brief description of this. Most of them, they present with periocular edema with proptosis, restriction of movement. And the infection is behind the orbital septum. The causes are extension from periorbital structures, exogenous source, trauma or surgery, endogenous, or it can be intraorbital. And already the classification by Chandler has already been described. And here you can see a medial subperiosteal abscess in this case. And this is an orbital cellulitis with opacification of the soft tissue or inflammation of the soft tissue. So orbital fungal, I'm not going into detail because this is going to be dealt with Adjani. So phycomycosis due to mucor, aspergillosis can occur in healthy individuals, and it spread to the orbit from paranasal sinuses. Orbital apex syndrome can occur with proptosis, ptosis, and loss of vision, and treatment would be amphotericin B and surgical debridement. Coming to the orbital inflammation, the most common would be idiopathic orbital inflammation, otherwise called as pseudotumor. And this is an uncommon disorder characterized by neoplastic, non-infected space-occupying orbital lesions. And presentation is usually acute with orbital pain, restriction of extraocular movements, proptosis, and age of presentation is usually 40 to 60 years. And usually it's unilateral, bilateral, then you have to think of any systemic involvement. So subclassification are acute anterior orbital inflammation, idiopathic orbital pseudotumors, orbital apex or superior orbital inflammatory syndromes, orbital myositis, angiitis, thrombophlebitis, and dacryoadenitis. And acute orbital anterior inflammation is characterized by inflammation of the globe, particularly the sclera and tenoids. And they can be acute or subacute, and usually the vision is decreased due to uveitis, exudative retinal detachment, papillitis, or perineuritis. Orbital apex syndrome, usually they present with headache, periorbital or facial pain, minimal proptosis, reduced visual acuity, RAPD, diplopia, and visual field defects, ophthalmoplegia, and optic atrophy, which is seen in the late stage. And these patients, we have to rule out inflammation like sarcoid, SLE, vaginous, and giant cell arteritis, Tolosa Hunt, idiopathic orbital inflammation, dysthyroid eye disease, infectious like fungi, and bacterial infections, neoplastic like lymphoma, nasopharyngeal carcinoma, iatrogenic trauma, and vascular. So there are a wide variety of diseases which can cause orbital apex syndrome. And usually the orbital apex is a portal of entry of all nerves and vessels to the eye. And this involves dysfunction of the optic nerve, third, fourth, sixth, and V1. And you can see the doing an imaging, there's an inflammation in the posterior orbit. And here the steroids are indicated to reduce the inflammation and to prevent compressive optic neuropathy, which can cause worsening of the vision. So you can see in this case, you can see the imaging, you can see fat straddling and also extraocular muscle enlargement. And here you can see in the last one, you can see an optic nerve compression. And Tolosa Hunt, this is an idiopathic granulomatous inflammation of the cavernous sinus with unilateral orbital pain and ophthalmoplegia. The inflammation can extend beyond the cavernous sinus. These patients can have optic disc edema and pallor, but visual acuity is rare. Loss of visual acuity is rare. And these are very much responsive to steroids, usually in 72 hours for pain, but permanent visual deficit occurs and relapses is very common. And these steroids counteract the inflammation and they reduce reduction. There's rapid reduction in pain within 24 to 48 hours. Ophthalmoplegia, they respond a little slower, and relapse occurs in 30 to 40% of the cases, even after successful treatment with steroids. And Tolosa Hunt syndrome is a diagnosis of exclusion. Coming to orbital myositis, here these patients presented sudden onset of pain with ocular motility, disturbance, and diplopia, conjunctival injection, which is usually focally located over the muscle, or the involved muscle. There may be eyelid edema and ptosis, proptosis, and more than one muscle can be involved, although this is less common than single muscle involvement. And this can be recurrent in spite of treatment. And most common muscle involved is superior medial rectus muscle. And you can see in histopathology, chronic inflammatory infiltrate. And steroids here, they inhibit the inflammatory pathway. Up to 80% can relapse, and it is less common in single muscle disease. Sometimes you can get multiple muscle involvement also in these kind of cases. Sclerosing type is again a variant, and these respond very poorly to steroids. You may have to give immunosuppressants or radiation to these kind of patients. This was a patient who did not respond to steroids, so we had to we excised the lacrimal gland, and this was a sclerosing type of dacryoadenitis. So coming to orbital angiitis, it's a non-specific inflammation of the orbital arteries
1 minute more.
and they don't have any systemic association, and acute inflammation involving the small vessels of the orbit. And they have non-specific acute orbital symptoms with like pain, just like any other orbital cellulitis. And dacryoadenitis, here the lacrimal gland is enlarged and they should tender and unilateral. And this again causes a shaped ptosis. And you have a flow which is pushed forward and downwards. And bilateral involvement, always think of systemic disease like sarcoid lymphoma, Sjogren's, and drugs like thiouracil. Viral and bacterial can also cause. Chronic inflammation can occur after irradiation to the lateral orbit. So these are viral dacryoadenitis and bacterial, and you have idiopathic and immune-related, and long-term systemic immunosuppressive may require long-term systemic immunosuppressive therapy. Sometimes can be associated with IgG4, where the relapse rate is very high and response to steroids is temporary. So these are tumor-like masses consisting of fibrosis and obliterative phlebitis, and they have IgG4 rich lymphocytic infiltration. Here you have to examine the salivary glands. They have diffuse lymphadenopathy, liver and renal function tests should be done. Serum IgG4 levels has to be monitored. They are treated with steroids, but still they have a high relapse rate, and they require long-term maintenance with steroid-sparing agents like rituximab. In case of recurrence, you need to do a biopsy, and they may need a surgical debulking or irradiation. So again, treatment of IOID is observation, which can be for relatively mild disease. Biopsy is required if there is it's persistent, and you need to rule out like other like lymphomas and other neoplasia. And systemic steroids, usually we give oral prednisolone 60 to 80 milligram per kg for three weeks, and then gradually tapered over few months. Radiotherapy can be considered there's no improvement after 2 weeks. Antimetabolites like methotrexate and mycophenolate mofetil can be necessary if they're resistant to both steroids and radiotherapy. Systemic infliximab, a tumor necrosis factor inhibitor, may be effective in recurrent or recalcitrant cases. So this follows one of the following patterns, like they can have a spontaneous remission without sequelae, or intermittent episodes of activity with eventual remission, or they can have a prolonged inflammation leading to frozen orbit. So vaginals, here 10% of the cases orbital involvement is present, and they present with proptosis with focal necrotizing vasculitis, and they have granulomas in the respiratory tract and glomerular nephritis leading to renal failure and death. And this is again another orbital thyroid is a very common cause of orbital inflammation. I'm not going into full detail because most of them know all the clinical signs and symptoms. So again, you can see here all the extraocular muscle enlarged with bilateral proptosis. And this is the difference. You can differentiate this from Graves. This is a tabular column, where many times it's where you have the mode of onset in acute orbital inflammation is acute, whereas in Graves is chronic or subacute. Pain is present, there's painless, and laterality, unilateral, bilateral. With signs we have symptoms. Usually they have a malaise in orbital pseudotumor. Steroid is responsive to in orbital pseudotumors, but less in Graves. And radiographic findings will be infiltrative mass, and whereas in Graves you have spindle-shaped extraocular muscle enlargement. And this is a management like conservative, medical, and surgical. So I'm just going to steroid alone, where you can give oral steroids 1 gram per kg body weight, weekly tapered, and if it is very severe, you can go for IV methylprednisolone. And this is the approach to orbital inflammatory disease: complete history, pleural lymphoproliferative, vaginous, sarcoid, and thyroid eye disease, and complete workup has to be done, and also granulomatous workup, X-ray chest, and other and imaging. So what is the mechanism of action of steroids? So they reduce cytokine production, inhibit leukocyte recruitment, stabilize cell membranes. They reduce vascular permeability and suppress inflammatory cascade. So what role does steroid play in infection or inflammation? So they have potent anti-inflammatory immunosuppressive agents, and they help reduce edema, pain, and compression. But what are the side effects? So they can worsen infection like viral and fungal. They can increase the blood sugar and also slower the wound healing, weight gain, Cushingoid features, osteopenia or osteoporosis. And in eye, you can have cataract and glaucoma. So you have to be very careful when you're giving a high dose steroids for a long time. So steroids in infection, the advantage is they accelerate resolution of inflammation and symptoms. There's faster improvement in proptosis, extraocular movement, and vision. And they found that steroid with antibiotic, especially IV steroids with IV antibiotics, they have a shorter hospital stay compared to only antibiotic groups. And also they reduce the need for surgical drainage, and also they prevent secondary damage like compression of the optic nerve, or and also they preserve the vision and also extraocular muscle function. And inflammation, there is a rapid symptom relief like reduction in pain, swelling, diplopia, and proptosis. Prevent long-term damage like scarring, fibrosis, and restrictive myopathy, and also prevent visual loss by reducing compression over the optic nerve. Caution in infections is, what cautions you have to take while giving steroids? They can suppress the immune response and mask symptoms if antibiotic coverage is inadequate. They may allow proliferation of bacteria. They can mask clinical signs like fever and swelling. Hyperglycemia will reduce the wound healing, and also gastrointestinal disturbances can occur. So these kind of cases we have to be very cautious. And also in inflammation, steroid dependence can occur, uncontrolled and unmonitored use, and patients may self-medicate and relapse on fast tapering. In inflammatory disease, long-term steroids are required, and they can cause cumulative side effects like weight gain, bloating, fluid retention, and we may miss other diagnoses like IgG4 related disease, lymphomas, and orbital mass. So there are some studies which initiate steroid after antibiotic response. So, or whether steroid has to be given along with antibiotic or after there is a response with antibiotic is still unclear. So optimal dose, whether it should be given IV or oral, and tapering schedule is also not standardized. And different population, like adults and children, they respond poorly. So protocols in orbital infection is culture is very important, but empirical treatment should always be started. Swab may give negative results, so you have to take pus from the abscess, which gives better samples. IV methylprednisolone can be given as 1 milligram per kg for 3 to 5 days, and then you can transition to oral steroids. Oral prednisolone also can be given as 1 milligram per kg per day for 5 to 7 days, and then taper. This can be co-administered with antibiotics. And inflammation, again, oral.
You have to conclude, doctor.
Yeah, I'm finishing. That's the last one more slide. We can give 1 to 1.5 milligram oral prednisolone, again gradually taper, and you monitor clinical improvement. And if there's no improvement, reassess the diagnosis. IV pulse steroids can be given site-threatening or severe diseases. This is the protocol for orbital inflammations. IV, same thing which I said, steroid or pulse steroid or IV methylprednisolone. Contraindication is suspected or confirmed fungal infection, immunocompromised patients, uncontrolled diabetes, uncontrolled infection, or poor response to antibiotics are suspected orbital masses like lymphomas. Thank you.
Thank you, Dr. Vijay, for a very extensive talk, which threw light into a whole range of topics in oculoplasty. Going back to the question, is steroids a friend of foe? So, Dr. Tarjini, I would ask you this question. How soon or how late would you start steroids in a case of orbital cellulitis? Dr. Tarjini?
So we typically tend to give about 24 to 48 hours of an antibiotic cover when you are suspecting a bacterial orbital cellulitis, following which you can start steroid. Now, there are exceptions here. Suppose you're dealing with a bacterial cellulitis where you also have a compartment syndrome. In that situation, you would do a surgical decompression of the orbit by a canthotomy and cantholysis, but also add medical decompression with steroids, because you don't want the optic nerve to lose its perfusion. And you'd be able to pick that up, compartment syndrome, by clinical signs as well as radiology.
That's fine. That's a good the answer I wanted. Dr. Vidya, can you take on? And Lakshmi, you could add some question too.
Madam, you have covered very well on the topics, all the contraindications, indications for steroid, everything I've told. But I just ask about your preferred dosing and taper protocol in case of IOID. That's one gray area for all of us. Like, how do you approach your case of IOID?
Yeah, I would first do all the blood investigations, like complete blood count, and also I would rule out granulomatous inflammation. And then if everything is normal, I would start the patient on oral steroids, 1 milligram per kg body weight oral prednisolone. And if there is improvement, then we will gradually taper. And of course, I also do imaging in these cases. And in case they don't, then we get maybe a second opinion sometimes from a rheumatologist or any other infectious disease specialist. Also, we do that. So, and if the lacrimal gland is enlarged, sometimes we also want to rule out any other inflammatory causes. So we get an opinion whether we can go for a biopsy or not.
And you did mention about radiation in IOID, madam. What's your experience in IOID, radiation and IOID? Do you routinely do or?
No. Actually, I don't have much experience with radiation. Yeah. Because it's given as a protocol.
Any of the panel members, do you routinely do radiation? Yeah. Dr. Tarjini, Dr. Roshmi, anybody do radiation for IOID in case?
I have a couple
Okay,
of...
go ahead, Tarjini.
Yeah, sorry, Vidya. Couple of cases that I have where I have, considered radiotherapy and actually given radiotherapy for orbital inflammatory diseases. These are those that are recurrent, have had several relapses, are to some extent, and where immunological therapy either the patient could not afford or was not suitable for immunological therapy. Those are the situations where, yes, I have considered radiotherapy for IOIDs and have given these patients radiotherapy. They have stabilized. Proptosis generally tends to reduce, and they tend to do well over a long follow-up as well.
Okay.
Okay, my take is that, so far I know that theoretically, yes, radiation works in orbital inflammation, but other than inflammation in thyroid eye disease, I have not had occasion or need to use radiation.
Exactly.
Whatever I've seen over the, whatever number of years, with a good, correct dose of steroids, as well as a combination of immunosuppressants, they are all manageable.
And what would be your go-to biologicals? Anything that you prefer, like
Okay,
if you want to
okay,
consider a steroid-sparing agent, which would be
yeah,
your
for
option?
steroid-sparing agent, possibly methotrexate is the safest. So my go-to is methotrexate. So,
Okay.
and of course, I do it in conjunction with the rheumatologist who works with me. Rarely, very rarely, I've needed to use rituximab, mostly for IgG4. Am I audible?
Yes,
Okay,
yes.
yeah. And it is known that GPA, granulomatosis with polyangiitis, which used to be known as Wegener's, that is best responsive to cyclophosphamide. So that is where we tailor. But other than that, methotrexate is the standard drug.
Go-to drug. Okay.
Dr. Anusia, you want to add anything to it before we go on to our next talk?
Yeah, so for me, I had like what I can recall, two patients where we had to use EBRT along for. So it is basically a stepwise algorithm that we use, as Dr. Viji mentioned. Like we start with steroids, intralesional steroids, all forms of steroid. If they are not responsive or resistant, or there is progression, then we move on to the next modalities. So both these cases, what is noteworthy to mention is both were sclerosing NSOIs. So many a times this sclerosing NSOI is a subgroup of NSOI which are extremely resistant to the common regimen that we give. So both these patients I had given rituximab, and following that also there was progression, and then I resorted to EBRT. So EBRT is much lower down in our treatment algorithm, but yes, we use for resistant cases, especially cases like sclerosing NSOI on histopathology.
Thank you. We go on to our next speaker, Dr. Kavya Vijanki. I really want all of you to stick to your time so that would encourage more discussions. She's again heads the LVPI Orbit Oculoplasty and Facial Aesthetics at Hyderabad. And she's going to tell us on Scan Me Right, CT scan versus MRI for an orbital disease. Dr. Kavya?
Yeah, hi. Hi, everyone. Good morning. Hope I am audible.
Yes.
So, I am Dr. Kavya M. Vishenki, currently heading Kadapa branch of LV Prasada Institute. So, let's take you through the basics of CT versus MRI in orbital infections and inflammatory diseases. As we know, the orbit is a remarkably complex structure, which is compact, crowded, and home to most delicate interfaces between the bone, muscle, fat, nerve, and vascular tissues. So when patient present with proptosis, pain, diplopia, or optic nerve dysfunction, our challenge is not only to see what is wrong, but to understand how it behaves within this confined space. This is where orbital imaging becomes indispensable. Among our imaging tools, CT and MRI stand as the two principal pillars, each illuminating different aspects of orbital disease. So coming to the principles, computed tomography works on X-ray attenuation. It quantifies the tissue density measured in Hounsfield units, giving us crisp anatomical resolution, particularly for bone, hair, and calcification. In contrast, MRI relies on the magnetic resonant properties of hydrogen protons, variations in relaxation times, T1, T2, and proton density generate exquisite soft tissue contrast, sensitive to water, fat, edema, and cellularity. So in essence, CT captures anatomy with geometric accuracy. MRI visualizes the physiology and texture within that anatomy. So this distinction defines our diagnostic approach to every orbital pathology. Let's walk through key categories, comparing how CT and MRI contribute and when each is indispensable in orbital infections and inflammations. So in patients with orbital infections, bacterial orbital cellulitis, CT is often the first step. Here's what you might notice: thickening of eyelid and postseptal soft tissues, indicating the inflammation posterior to the orbital septum, infiltration of the fat, suggesting deeper orbital involvement, opacified ethmoid or adjacent sinuses, hinting at sinus origin infection, and sometimes bony dehiscence or wall erosion, which is an early warning sign of aggressive spread. So the combination of orbital fat stranding and sinus opacification are classic indicators of infection spreading from the sinuses into the orbit. Now look at the MRI. While CT maps anatomy, MRI reveals soft tissue subtleties. So fat suppressed T2 images shows edema and inflammation within the orbital fat. It highlights the regions of restricted diffusion, characteristics of pus with rim enhancement, indicating the abscess formation. So restricted diffusion help in differentiating an abscess and simple inflammatory edema. So restricted diffusion points to viscous pus, distinguishing an abscess from the diffuse edema. So in patients with orbital apex or intracranial spread, CT gives clue if there is any bony erosion or sinus destruction, but subtle intracranial or cavernous sinus involvement may be missed. Whereas MRI is excellent for detecting dural enhancement, cavernous sinus involvement, or optic nerve sheath edema, critical for preventing vision or life-threatening complications. In suspected invasive fungal infections, MRI can reveal non-enhancing necrotic tissue and early soft tissue invasion before it's apparent on CT, guiding urgent antifungal or surgical intervention. So to conclude, in orbital infection, CT shows the structural impact with sinus involvement, orbital fat stranding, and details of early bony changes, whereas MRI confirms soft tissue inflammation, abscess formation, and intracranial or orbital apex spread. Moving to the inflammatory conditions, starting with thyroid eye disease, apart from globe displacement, the most important thing is to look at the extraocular muscles. On CT scan, we notice prominent enlargement of muscle bellies, often the inferior and medial recti. Interestingly, the tendon insertions are spared, which is a classic pattern which already gives us a clue. Now on MRI, the same muscles are enlarged, but here the added insight is they appear much brighter, which indicate edema and active inflammation. So while CT shows us the anatomy and structural enlargement, MRI provides information on disease activity. Next is to consider the orbital fat. On CT, we see increased orbital fat volume, contributing to the proptosis. It appears homogeneously dense, giving a clear picture of orbital crowding. On MRI, the fat is hyperintense on T1 weighted images, allowing us to distinguish it clearly from inflamed muscles or other soft tissues. So while both modalities detect fat expansion, MRI offers better tissue characterization. Regarding optic nerve involvement, on CT scan we might see indirect signs such as muscle enlargement compressing on the nerve, but the details are limited. On MRI, we can detect the compression, stretching, or early signal changes, which are crucial for predicting thyroid optic neuropathy. So MRI gives us a functional insight, not just structural. Start with CT for structural assessment and decompression planning while evaluating thyroid eye disease, which is an excellent for anatomical mapping, whereas MRI is superior for soft tissue contrast, which assess the activity, inflammation, and optic nerve status. So coming to the idiopathic orbital inflammatory disease, in CT scan, we can observe diffuse, poorly defined orbital involvement, which reflects the inflammation throughout the orbit, along with myositis changes, orbital fat stranding indicating inflammatory infiltration, lacrimal gland enlargement indicating dacryoadenitis, and possible optic nerve involvement. Whereas in MRI, in T1 weighted images, it shows hypointense orbital tissues, especially in chronic stages, whereas T2 weighted fat suppressed images shows active inflammation, which appears hyperintense, and chronic fibrotic changes are hypointense. Whereas post-contrast imaging demonstrates homogeneous enhancement consistent with active inflammation. So similar to the thyroid eye disease, CT scan gives more structural assessment, whereas MRI gives more soft tissue contrast in case of inflammatory diseases. And I don't know whether time is sufficient or not. Just briefly I'm showing you different orbital tumors and mass lesions. On CT scan, you can see well-defined lesion in right eye, whereas in MRI, you can see bright signal with progressive centripetal contrast filling, indicative of cavernous hemangiomas. And MRI is the imaging modality of choice for optic nerve sheath meningioma due to its superior tissue contrast, which can show the characteristic tram track sign. Whereas CT is less sensitive for soft tissues, it is better at detecting calcifications within the tumor and assessing the bony anatomy. And coming to the orbital lymphoma, MRI is superior to CT due to better soft tissue resolution, allowing for more accurate depiction of lesions' extent and characteristics. And MRI is the most valuable tool for diagnosing and characterizing vascular malformations. In high velocity AV malformations, flow voids are noted, whereas in low flow venous malformations, flow voids are absent. Lymphangiomas are usually characterized by cystic areas with hemorrhagic components. So to conclude, for trauma, foreign bodies, orbital wall fractures, or initial anatomical mapping, CT is usually the preferable one. When soft tissue details, optic nerve extensions, or vascular shunts are in question, MRI is essential. For suspected infection, CT gives the speed and sinus anatomy. MRI refines the margins, necrosis, and intracranial spread. In tumor evaluation, both the modalities are complementary. CT for calcification or bony details, MRI for tumor tissue characterization and extension. For follow-up, MRI is preferred for repeated assessments and distinguishing scar from recurrence. And always tailor your request, specify contrast, fat suppression, diffusion, or angiographic sequences when needed, and coordinate with your radiologist. So thank you, everyone.
Thank you. Thank you. That was a very nice talk. Very nice. And gave a very good picture of the role of CT and MRI. Dr. Vikas, I think we need to see you and hear from you too. So
Hi,
would you
good evening, ma'am.
say
Hi.
that a contrast is always needed in these cases, or it is specific when you would decide to ask for a contrast?
No, actually, contrast is not really necessary in most of the cases unless you are really looking for a vascular pathology. Dr. Kavya very nicely summarized everything and compared CTs and MRIs in the same slides, which is a very good format that I would compliment her for, that, same pathology is being shown as CT and MRI. Only thing that I would like to add here is that when considering CT versus MRI in these cases, one has to understand that MRI takes significantly longer time for procuring the images. And a lot of patients may be in discomfort due to infection or inflammation, acute inflammation, maybe claustrophobic, maybe obese, and maybe having difficulty lying down for a longer period of time in the machine. So for all those patients, CT is a very valuable tool and gives us a lot of information. Of course, for soft tissue details, nothing beats MRI. But if you are looking for something like for an infection, a patient is there with an infection and you just want to see whether there is a subperiosteal abscess present or not, whether there is a sinusitis coexisting or not, a quick CT will give you as much information as you require in a much shorter time and at a much lower cost. However, MRI is definitely valuable when you're looking for cavernous sinus lesions or you're looking at orbital apex or the optic nerve involvement. And the clinical findings will dictate you towards which side you have to go for. So yes, both have their own roles. I would just like to summarize this. You have to choose based on your clinical findings as to you would go for a faster modality. You just need basic information and a quick information versus you need more detailed evaluation of the optic canal, apex, cavernous sinus, etc. And also another thing is if you are suspecting some bony changes like which may occur in fungal cellulitis and sometimes these lacrimal gland masses you may be having problem differentiating between tumors and inflammation. So if you have adenoid cystic carcinoma, a lot of times they will cause a lot of bony erosions, bony changes. So on CT only you can, just have a look at the CT quickly and make out, there's a higher possibility of a malignancy there. So it depends on your clinical examination and then you can tailor your approach towards whether you go for CT or MRI. I feel that in a lot of our clinical cases, CT also is enough. We don't need to go for MRI in a lot of our cases, but of course there are specific indications for MRI, which Dr. Kavya has detailed. So thank you very much, ma'am.
I
Thank
had
you.
a doubt if I can. Kavya, can you address that question which was asked in the beginning? Hi, uh, whether serial CTs or serial imaging is necessary during orbital cellulitis? This question had come up, and how practical is it? So, any of the seniors, Dr. Tarjani, Dr. Vikas, can you comment on that, or maybe Kavya herself, um, Dr. Roshmi?
See,
Which cases would you do serial imaging when
probably
there
in
is a
fungal,
case of orbital
probably
cellulitis?
in fungal cellulitis, I would require serial imaging.
Mm.
Whereas in most of the bacterial cases, clinical signs, once they are resolved, you treated the patient well with antibiotics or drained their abscess, and clinically there is a resolution, then there is no need for a repeat imaging. But in fungal, yes, which can be a smoldering infection and can sometimes come back, there there is a requirement for serial imaging and MRI would be preferred there.
Okay, I have a little addendum to that because I agree with you very much. But supposing a patient is presenting with orbital cellulitis without abscess, okay, the patient is not responding so well to the antibiotics. It looks like things are getting worse. So we really want to repeat an imaging to see whether a collection or abscess has formed and obviously exactly where it is so that we get an idea of how to drain it. Apart from that, especially in infective cellulitis, bacterial cellulitis, one good way to follow up is using the CRP. The inflammatory effect comes down along with clinical signs and symptoms improving. So you also know that, yes, the inflammation is improving. So CRP helps with that.
Couple of other points, if I can just add here, I agree with both Vikas and Roshmi, would be, say you have cellulitis from sinusitis origin, right? Your ENT might want to repeat the scan again to perform a sinus debridement if that is deemed necessary. Or say you had cellulitis from an acute dacryocystitis, which you couldn't pick up earlier because of inflammation everywhere. And now the inflammation has settled and you can see that the lacrimal sac is swollen. In situations where this is in the setting of trauma, you're thinking of a saldo or something like that, again, you want to do a CT, repeat a CT, especially a CG to see what the lacrimal system looks like. So it's very tailored, suboptimal response, I would say, to standard antibiotic care. Suspicion of a subperiosteal hematoma or an orbital abscess that you want to drain. and other pathologies that come up once the initial inflammation subsides, or other clinical signs that come up once the initial inflammation subsides, should be certainly indications for imaging a bacterial cellulitis again. Fungal cellulitis, we'll discuss that, and of course it requires serial imaging.
Yeah, thank you so much.
Thank you very much for a very nice discussion. We go on to our next speaker, Dr. Tarjini Dave, who's going to be talking on orbital fungal infections from suspicion to surgery. On to you, Dr. Tarjini.
Thank you so much for this invitation, team I Foundation. I'm very glad to be here. I hope, Dr. Chitra, your hand is okay. I noticed a little plaster on your hand, and I'm hoping you're fine.
Yeah.
I'll just get started with the talk. So I was tasked with covering orbital fungal infections from suspicion to surgery over the next 10 minutes. And the way I've structured the talk is that I'm going to bring to you these 10 points that I have listed out on what is the hallmark of a fungal disease, how bacterial and fungal disease differ, what is the diagnostic urgency in terms of bacterial versus fungal, what are the classic presentations, the diagnostic pathways that you follow in a fungal infection, what helps you improve the yield of fungus in an orbital cellulitis, the available treatment options at this point of time, with the prognosis of a fungal cellulitis, and finally wrap it up with some key takeaways. Now, when you're thinking fungus, the first thing in your mind is an immunocompromised host. Now, this is a traditional host who's either diabetic or immunocompromised from certain other things, like, say, an organ transplant and is on immunosuppressives, or say, diabetic ketoacidosis or HIV or something like that is going on in your mind. And that's very true. You have to have some host factors for the patient to develop a fungal cellulitis. Fungus is ubiquitous. It's everywhere. It's sitting in your nose, my nose, everywhere. But it doesn't infect us unless and until there is a dip in our immunity. And therefore, some amount of immunocompromise generally is present in these patients. Now, you tend to have this classic distinction between the mucor group that affects the orbit and aspergillus. And this difference is because aspergillus sort of is more on lines of a fungal granuloma that you will see with a relatively quiet eye, versus that you'll have mucor, which produces the classic full-blown fungal cellulitis and may not have a quiet eye, and may present with inflammation of the eyelid, of the conjunctiva, of the entire orbit, as well as proptosis and telltale necrosis or the eschar that you tend to see in these patients. Now, I've just put up these two cases here, which look very similar. The right eye involved in both the cases. Both have sinusitis, as you can see on the imaging. This is very tense eyelid edema, very difficult to even part the eyelids, versus that this is relatively, less eyelid edema, but a lot of necrosis and eschar that you see. So we had to peel off that eschar, and underneath which we saw a lot of necrotic tissue here. So how, by this presentation, will you be able to classify whether this is fungal or bacterial? So you're going to look at certain specific things. You're going to look for all the host factors that we discussed. You're going to look for vision and response to antibiotic. When vision is compromised early, you think more on lines of fungal disease. And when you have poor response to antibiotics, that again is more like fungal disease. Versus that you have this patient here whose vision was preserved, and he responded very well to antibiotics. These are both the patients post-operatively. Here there's an extensive orbital debridement with intra-orbital injection of antifungal that was done, following which the fungal cellulitis resolved. Whereas here the patient was treated just with IV antibiotics, the routine protocol, followed by a steroid that was added 24 to 48 hours later. And this is him about 2 to 3 weeks following treatment. So this distinction is important because the morbidity and mortality involved with bacterial cellulitis is very low. It's about 1 to 2%. Versus that with fungal orbital cellulitis, the mortality rate can sometimes cross 50%, especially in the setting of mucormycosis, that too if the host is immunocompromised. If the fungal cellulitis involves the brain, the mortality rate actually jumps up to 80 to 100% as well. And therefore, the urgency to pick it up early so that you can treat it early. Now, what are the classic presentations of a fungal orbital disease? So you may see something like this, where you have a orbital ill-defined lesion with a quiet eye, some amount of ptosis there telling you that the apex of the orbit is also involved. Obviously, he has proptosis. So this is a gentleman who had aspergillosis, and you can see the sino-orbital involvement with bone destruction, which is very classic of fungal. Sometimes you may have very mild sinusitis like this with a Tolosa Hunt-like picture where the apex is involved and total ophthalmoplegia. Any setting of total ophthalmoplegia where the sinuses are hazy, rule out a fungal disease before labeling it as Tolosa Hunt and treating with steroids. Or you may have a quiet eye like this with a discharging sinus, which is again very common in fungal diseases. And you will have some amount of bone destruction that Vikas was earlier mentioning, which you can pick up on a CT scan like you see over here on both the soft tissue as well as the bone window, where you see the destruction of bone. Typically, fungal disease involves more of the inferior orbit and the medial orbit, and this is because pterygopalatine fossa, which lies inferolaterally, is actually a reservoir where fungus sits, and it's easy for it to enter from the inferior orbital fissure into the orbit, like you see on the left side over here. And it's always a good idea to look at the pterygopalatine fossa in these patients, and here you see the response following treatment, where you can see that the granuloma itself has reduced in size. Mucormycosis by itself has a completely different set of presenting signs and symptoms, and here your MRI is vital. CT scan does not give you this information. You need a T2 weighted fat suppressed MRI, contrast enhanced, to tell you that there is angioinvasion. Like here, the entire superior ophthalmic vein is thrombosed. So you can see a post-contrast scan where contrast is not taken up in the SOV, which means that there is dead tissue there, which is not taking up contrast. And this is a hallmark of fungal disease, which is known as angioinvasion. You see that in the cavernous sinus as well. Typically, when you want to look for necrosis, what you will see in a contrast-enhanced MRI is hyperdensity with central hypodensity, a central area where blood is no longer reaching and you have necrotic tissue. And you tend to see this very frequently in mucormycosis. In mucor, what you also see is an ESHCA, a skin necrosis. This is a patient with acute lymphoid leukemia who actually had mucormycosis because of the immunosuppression. And all we had to do is reverse his immunosuppression, inject a little antifungal here, and give him systemic antifungal with sinus debridement. And he actually lives. His lymphoma is controlled, and so is the mucormycosis. So here I've listed out all these red flags, which sort of tell you that you're not dealing with a bacterial cellulitis, think fungal. And why do you need to pay attention to these red flags? That's because the diagnostic yield of fungus is very, very low. So how can you go about getting tissue? So essentially, when you're thinking fungal disease, you need an MRI with contrast. With that, try to stage whether it's just in the sinuses and the orbit or has spread to the brain, and then try to get some material. It's always better to get an orbital tissue biopsy rather than random pus, because the pus will not be sensitive enough and will not tell you what the organism is. So get that material, subject it to direct microscopy with calcofluor white and KOH mounts, send it for fungal cultures, and also try all molecular identification techniques such as PCR and advanced techniques to actually try and figure out what sort of fungus it is. Certain times when it is a widespread disease, when there's mucormycosis or aspergillosis throughout the body, the blood serum galactomannan assay levels will also help you in figuring out how the response is, just like how Roshmi mentioned about C-reactive protein in bacterial cellulitis. A serum galactomannan assay will help you follow up a fungal cellulitis. And in this busy table, what I wanted to highlight is that it's the histopathology pathologies, taking that tissue and sending it for pathology, not only microbiology, that gives you the best yield of fungus. Fungus is very difficult to see on a smear or grow on a culture, and even PCR sometimes may not be positive, but it's the histopathology which will give you that diagnosis. And where do you take tissue from? Don't take only the necrotic tissue, take the edge of the involved and the healthy tissue. The devitalized tissue at the invasive front of the disease is what you need to biopsy to get the maximum yield of diagnosis. So here are just some sampling tips that I have put up. Don't go for the pus, go for tissue biopsy, sample the invasive edge, send it for microbiology smear and culture, add for a PCR when diagnosis is not available to you. You can also add rapid methods of intraoperative detection like frozen section to sort of give you faster yield of whether there is fungus or not, and so you can target your treatment. And when you've got everything negative, but you still have a strong clinical suspicion that this is fungal, go back and biopsy. You may get a positive fungus on any of these treatment options. Sorry, diagnostic modalities. Quickly summarizing the treatment, aspergillosis, the drug of choice these days is oral voriconazole.
Doctor, 1 minute more.
Yes, you can add orbital voriconazole injections as well for faster recovery losses, and you can see him post 6 months of oral and 3 injections of orbital voriconazole. The orbit settled, a similar patient where again oral as well as IV intraorbital treatment with voriconazole was used. When it comes to mucor, it's important to reverse the immunosuppression, start on amphotericin B, and start surgical debridement with intraorbital injection of amphotericin B. What you're trying to do in mucor with your orbital debridement and injection is to overtake the fungus. You don't want the fungus to produce necrosis faster than your drug reaching there, and therefore orbital injection of the drug is very, very important. And here are 3 patients, all of which were referred for an exenteration, but they live, they see, they have an eye, all treated just with intraorbital injection of amphotericin B along with IV amphotericin. Incomplete in the context of fungal disease without involving your ENT surgeon, your infectious disease specialist, your neurosurgeon, your endocrinologist to manage the diabetes. And it's always good to advocate for rational use of steroids because it's always better prevented than pushing the patient into that 50% mortality category. To summarize on the prognosis, as far as aspergillosis is concerned, the prognosis is better compared to mucormycosis. But with all of what we've mentioned in mucormycosis as well, you can reach a globe salvage rate of about 75% and a vision salvage rate of about 50% in these patients. So here is the key takeaway from my talk. Have a high index of suspicion of fungal cellulitis in diabetics and immunocompromised patients. Go for an MRI and tissue biopsy, and as far as possible, use rapid diagnostic methods, voriconazole for aspergillosis and amphotericin for mucormycosis. Thank you so much.
That was a brilliant talk, Dr. Tarjini. I mean, being a anterior segment surgeon, I mean, I enjoyed every second of it, learned so much. And I truly believe there is no need to even discuss it because you've just said it all. So we are going to go on to the next talk unless Vidya wants to add something, Vidya. Just a brilliant talk we heard now. Vidya?
Yes, madam. Madam, I just have one question to Tarjini. That was an excellent presentation, Tarjini. As always, I learned so much. You talked about galactomannan. In real orbital world scenario, how often do you use serum galactomannan? My ENT colleague vouches for it. She says go for galactomannan. That will give you high suspicion of this thing. I don't find much of useful. How do you do it in your practice?
So for diagnostic dilemmas, you can certainly consider serum galactomannan assays when you're not very sure whether this is a fungal disease or not. In fungal disease, your oral antifungals go on for at least 6 months and they are expensive, both voriconazole as well as Ampho-B. In the context of aspergillosis, if you do serial galactomannan assays, you will be able to see a downfall in the levels, and you know that at a particular level it plateaus out, which is when you can safely stop the oral antifungal. So its role is bigger there than in the diagnosis, in my opinion.
Okay, got it. So,
Go on to our next speaker, Dr. Rushmi Gupta, who's going to be talking on thyroid eye disease, what's new, what's practical. On to you, doctor. You have 6 minutes to say all that you have to say.
Okay, let's see. I'm trying to get, okay. Here we go. Is my screen visible?
Yeah.
yes.
Well, thank you, Dr. Chitra, for giving me this very interesting topic. I know almost everybody knows a certain amount about thyroid eye disease. So I'm not going to talk about what is already known to people. And I'm not even going to go through, a PubMed laundry list of what are the newest articles that have come. So what I'm actually going to say is the ways my approach or practice of thyroid eye disease have changed in the last several years. So I have no financial interest in the products mentioned. And so in this, because I have 6 minutes, I'm going to restrict myself to imaging, how I approach coexisting systemic conditions, and medical management of thyroid orbitopathy. So in imaging, I'd say Kavya did a beautiful job of talking about imaging in the orbit. Among the investigations, we know that when I started off, antithyroid antibodies were not widely available. So any which one was available, we'd ask for that. So antithyroglobulin is not specific. Anti-TPO is more often present in Hashimoto's thyroiditis rather than Graves'. So now antibody against TSH receptor, TRAB, is available quite widely. And if it is more than 5 times normal, that indicates a higher risk of Graves' orbitopathy. As well, if there's isolated orbital disease, which has a TRAB positive, it's more likely to develop systemic disease within 2 years. Now we talk about orbital imaging. It is not required routinely. We may need it to complete the diagnosis by Bartley's criteria. If there's asymmetric proptosis, we need to rule out a space-occupying lesion. And in dysthyroid optic neuropathy, it might be the corroborative evidence where there's an apical crowding. Of course, when we are planning for surgery, we want the orbit to be quiescent. So we use orbital imaging if we are in doubt to assess activity. And of course, we are going to assess the bone and muscle thickness. And this is where a CT scan will be more useful than an MRI when we are planning for surgery. So once again, T2 shows hyperintense signals in the recti in active disease. As well as in active disease, there's contrast enhancement. So Barrett's index is something else that we use where the thickness of the muscles divided by the total width of the orbit is considered. And if it is more than 60%, there's a higher chance of getting dysthyroid optic neuropathy. But this is where I think the crux is. When you see the contrast is being taken up patchily, you know it's a very active disease. If clinical signs and symptoms don't tell you, this is where we would go to decide whether I'm going to wait a little more or decompress or continue the medical management. And of course, as we said, CT scan is what I use in planning surgery. But let's look at what has come in more recently to my notice, that we talk about systemic disease and thyroid orbitopathy. And a couple of years back, we got a major review published between thyroid eye disease and its association with diabetes mellitus. And this was triggered by 3 articles in the same year from India, which showed diabetes as an independent risk factor for severe thyroid eye disease. So if we look, this very busy chart, there are metabolic factors and inflammatory factors, the orbital fibroblasts. So the metabolic factors, including diabetes, obesity, they all trigger more of inflammation. Metabolic factors trigger hyperinsulinemia, which again in turn affects the IGF receptors. Vitamin D also is going to cause inflammatory activation. So in this whole cascade, ultimately what happens, diabetes comes in as an independent risk factor for both severity and sight-threatening disease. Metformin has an anti-inflammatory and anti-fibrotic effect. And rosiglitazone can actually trigger thyroid orbitopathy. We also look at the serum lipid levels. The statins inhibit differentiation of orbital fibroblasts. And in fact, adding atorvastatin to IVMP has improved outcome in orbitopathy. Vitamin D itself are found to be, they're going to be lower than vitamin D is seen lower in patients with higher levels of anti-thyroid antibodies. So these are the three things routinely that I've started asking for when I'm dealing with the thyroid orbitopathy patient. Control your blood sugar level, control your lipid profile, and control your vitamin D. Not even borderline, get it well into the normal levels. Next, we talk about medical management in thyroid eye disease. And while we know corticosteroids are going to suppress the B cell pathway, the T cell pathway, increase the apoptosis of these cells, let's actually look at what has come out to be the game changer in thyroid orbitopathy and our understanding of it. If we look at an orbital fibroblast, many factors are acting on it, including TSH receptor antibody, which acts through the IGF receptor. And we are gradually figuring out a way to block each of these pathways. For instance, the B lymphocytes can be blocked by the rituximab. The T lymphocytes can be blocked by mycophenolate, cyclosporin, and methotrexate. The IL-6 secreted from T lymphocytes can be blocked by tocilizumab. And the IGF-1 receptors can be blocked by teprotumumab. So overall, the guideline from UGOGO is still IVMP, but we add MMF every day from the 6th week onwards for a total of 18 to 24 weeks. This is the recommendation of UGOGO. So when we look at an RCT of IVMP versus IVMP plus MMF, we know that CAS is better controlled with a combination of two. However, this has GI side effects, but it makes no difference in dysthyroid optic neuropathy. It makes no difference in relapse rate. So it's a great option for controlling the inflammation. One more new thing that has come up in the last 5 years is that there's actually a chart for determining whether a patient is responding to management or not responding to management. So if the vertical fissure height decreases, if 1 out of 5 inflammatory signs improve, proptosis decreases, and ocular movement improves, we know that the patient is responding. However, over a period of 1 to 3 months, if the vertical fissure height is increasing, proptosis is increasing, or diplopia is increasing, we know the patient is getting worse, not responding to management. And this clarity is very important in determining what is our next step of treatment. We are looking at 6 to 12 months of active disease. We also need to look at the second line in active thyroid orbitopathy, where all these things come in: orbital radiation, rituximab, tocilizumab, and teprotumumab. And in fact, after we've given the first set of IVMP, which with a cumulative of 4 grams, if we see that the patient is still active eye disease, we can repeat a liver function test and give a second cycle of IVMP with a cumulative 7.5 grams. Let's look at the other immunosuppressants. Azathioprine or methotrexate is used as a steroid sparing agent and in patients unresponsive to steroid. It can be given in combination with a single infusion IVMP or low dose steroid. However, for these, time is needed for the onset of action, at least 3 to 4 weeks. So it's not going to act rapidly on severe active eye disease. So rituximab, again, there are contradictory results. However, there are studies which tell us that it reduces the relapse in active eye disease. Even though the standard dose is 2 doses of 1000 milligram, it's also been seen a single dose of 500 milligram also may be beneficial. Rituximab on its own does not prevent dysthyroid optic neuropathy, and it can cause cytokine release phenomenon and have a paradoxic increase in inflammation. Rituximab itself is very good for patients who keep relapsing. So in patients where steroid plus mycophenolate has been insufficient. Orbital radiation controls disease activity and is particularly good in patients with ocular movement dysfunction. This, however, is contraindicated in diabetic patients. Tocilizumab inhibits the IL-6 receptor. A lot of it has been used during the COVID-19 pandemic, but it shows improvement of soft tissue inflammations. But among the side effects, it can increase infections. And we obviously, in our population, we need to check for Cox disease beforehand. One advantage tocilizumab has over rituximab is that it can be given by the subcutaneous route. Teprotumumab has, got a lot of press. It's an IGF-1 receptor antagonist. It apparently has good effect on activity as well as proptosis, but obviously since, it's not available for us, it'll be probably several years before we have access to it. So to summarize, for me, new and practical changes in my practice include areas where we've talked about imaging, medical management, and management of systemic conditions. Thank you.
Thank you. Thank you, Rashmi. It was a very wonderful talk. Vidya, would you take some question? Very nice talk. Vidya? Yes.
Yes, madam. I think Roshni, as always, you presented very well, all summarized very nicely. So I don't have any particular question to you. Maybe I'll ask Lakshmi to have anything to add, Lakshmi, or any questions that you would ask.
Can I ask one question?
Yes, sir.
Yes, please.
Hi, Roshni.
Hi.
So just wanted to ask you, one thing is that, have you started giving mycophenolate to your patients on IVMP?
Yes, in fact, I start off with mycophenolate quite soon because mycophenolate itself will also take time to kick in. So I want mycophenolate firmly in place by the time my IVMP is closing off. So by maybe 4th week, I would start off mycophenolate.
What is your typical dosing pattern that you prefer?
Okay, we start off with 500 mg twice a day, which is 1 gram per day, but that is inadequate. The actual dose required is 2 grams per day. So initially, couple of weeks of 500 twice a day, we'll move to 2 tablets morning, 2 tablets evening. So a total of 2 grams per day.
And you do it with the help of a rheumatologist or you are yourself?
It's either the rheumatologist or the endocrinologist, because the patient is obviously never only with me.
Right. Yeah. I think that's a great addition to what we are already doing. IVMP, everyone is doing, but probably yes, and especially in cases where the response is not so good. In those cases, mycophenolate can be started early. And is anybody using the 3 weekly protocol for IVMP, or everybody has shifted to 1 weekly?
1 weekly.
1 weekly.
Nobody is using the 3 weekly protocol. Okay.
I think I'll go on to our next talk by Dr. Marian Paul. I was a senior consultant and head of the Department of Orbital Oculoplasty and Ocular Oncology at Giridhar Eye Institute, Kochi. So let's hear from you, Dr. Marian, not just idiopathic orbital inflammations that mimic it.
Yeah, good evening all. Thank you so much, Dr. Chitra Madam and Dr. Vidya and the team of Eye Foundation for giving me this opportunity. Hope my slides are visible. Yeah, okay. So my talk is confined to the mimickers primarily. So I thought I'll share a few cases. So this is my first case. She is a 61-year-old female presented to us with lymphedema, was treated elsewhere with steroids and presented to us after 8 months. She's a known diabetic also since 6 years. You can see a mass in the medial orbit. So we did a biopsy since she was already on steroids. Turned out to be metastasis from carcinoma breast. So here the thing to highlight is CA breast treated 8 years back. So most of the time the patients might not tell you the history of a malignancy because this happened 8 years back. So it's our responsibility to elicit the history of any malignancy in a patient present with inflammation, especially in little older age group, above 50 years of age. This is again another patient, 89-year-old, again present with the lymphedema. He also told the history after questioning only. So he had CA prostate treated 10 years back. So we did a CT scan, showed superior mass with the focal osteolysis. Biopsy proved it as adenocarcinoma, and he underwent RT and he is still alive at 1 year follow-up. So distant metastasis can mimic orbital inflammation. Now come to the another case, again 55-year-old male, treated as scleritis with an abscess in the medial side. But if you look at, there is proptosis and there is a lymphedema and congestion chemosis. Now look at this CT scan. So there is a mass rising from the ethmoid sinus invading the orbit, causing globe indentation. So here it's very important to detect the proptosis, and this is another case where metastasis from the adjacent organs can mimic orbital inflammation, and sometimes you can miss. So again, it's very, very important. So in this set of cases, what is more important is elicit the history and imaging. Imaging, there is a definite pattern of involvement to assess the primary site. In breast, usually diffuse and irregular along the recti muscles, whereas in carcinoma, renal cell carcinoma, melanoma, they are more circumscribed. Diagnosis is always with open biopsy. FNAC in very frail or poor candidates for surgery. Treatment is in conjunction with the oncologist. So now move to the second group. Here is a young female, 23 years, presented to the ENT surgeon with the deafness, and she had undergone a biopsy from the tympanic membrane for the diagnosis. Turned out to be non-specific inflammation. Meanwhile, she developed orbital inflammation in the left eye and she was referred. You can see there is dacryoadenitis with the proptosis and diffuse orbital inflammation. Her CT scan showed what was more catchy. There is a globe indentation, extensive globe indentation, and there was a diffuse orbital involvement. So in this case, we didn't wait for steroids. We directly did biopsy because since it is globe indentation, it is not regular inflammation. The biopsy turned out to be GPA, granulomatosis polyangiitis. So the deafness was also a part of GPA. Limited GPA can affect the head and neck region, and dacryoadenitis is one of the most common presenting symptom or sign in case of GPA. She was treated with rituximab in association with the rheumatologist, and she did well. So in dacryoadenitis with the diffuse orbital involvement always have a suspicion of a systemic disease, and bone changes also will give a clue. Coming to the case 3, lymphomas is the biggest mimicker of orbital inflammation. So he is a elderly man, 60-year-old, presenting with orbital cellulitis-like picture. You can see diffuse mass involving the supralateral quadrant. Biopsy was suggestive of diffuse large B-cell lymphoma. He was treated with the oncologist. So there are various papers how will you differentiate between orbital inflammatory disease and lymphomas. CT scan, even though CT scan is the primary imaging of choice, sometimes in MRI with the low ADC, if you tell the radiologist specifically, they might help you and you can accordingly proceed with the biopsy initially, because both will respond to steroids, inflammation as well as lymphoma. So this was an orbital lymphoma. Again, another case presented 45 years, recurrent retinas, treated as scleritis, periorbital inflammation. You can see a small inflammation near the middle rectus muscle. Even the MRI was reported it as orbital pseudotumor, but we have done a CT scan and you can see there is involvement of the rectus muscle as well as the belly of the muscle. We did biopsy, turned out to be mantle cell lymphoma. So here we have to differentiate this from thyroid eye disease. Thyroid is, you can see the tendon is paired, only the belly, and usually bilateral, most of the time bilateral. So we directly went ahead with the biopsy and turned out to be lymphoma. Coming to the fourth case, this is a 50-year-old female presented with a fleeting lid edema, like recurrent lid edema without any pain. So that is very, very important. Usually in orbital inflammation, you will have pain, lid edema, proptosis, etc. But here, lid edema without any pain. So this was the clinical picture, mild redness and mild swelling in the periocular region and mild proptosis. CT scan showed a parasitic cyst suggestive of cystic circus. She was treated with steroids and albendazole and she became all right. In our part of the country, diarrhea is also very common. Here again, the catch point is lid edema without any pain and lid edema associated with the itching. So parasite is another mimicker. Coming to the fifth set, she is a 68 female, presented with swelling right eye since 3 weeks, right eye vision 6/18 and RAPD. So you can see there is a phimosis, congestion, lid edema, etc. There is orbital inflammation again, can be CCF, can be TRO. Imaging MRI did not give any much clue. CT scan showed dilated superior ophthalmic vein and she was diagnosed to have CCF and she underwent intervention by the interventional radiologist and she became all right. So CCF is also a mimicker of orbital inflammation. Coming to a few pediatric group, 8-year-old boy, a facial diplopia, vague trauma history. So this is a clinical picture. This is characteristic of round cell tumors, rhabdomyosarcoma, neuroblastoma, chloroma, leukemia. So MRI was a little confusing, but we did biopsy and turned out to be rhabdomyosarcoma. This is another child, 11-year-old boy, presenting with the recurrent lid edema on the left eye. Again, all the parents gave a vague history of trauma. You can see the CT scan shows bone erosions. That can be dermoid with rupture inflammation or it can be lung enhanced histiocytosis. Went ahead with the biopsy and turned out to be LCH. We treated with the intralesional triamcinolone acetonide on oral steroid and he became all right. So to conclude, these are my few cases in 6 minutes. To conclude, to get the mimickers out, we have to get a proper history, especially in cases of metastasis, proper imaging and biopsy first and treat accordingly. Thank you so much and I take this opportunity to invite all of you for the next annual conference in Kochi in April 2026. Thank you.
Again, wonderful talk, Dr. Marian. Very nice. It's beautiful examples. Vidya, would you like to take some question before we go on to our last speaker?
I don't have a question, madam, but Marian did a very good job. All cases are
These are the few mimickers
very
which I
good.
thought
Instantly,
of.
we had one case today which had bilateral, which had a bilateral medial rectus mass enlargement along with previous history of breast cancer.
Yeah.
So probably we are also thinking in terms of CA
Metastasis.
metastasis. So we'll hope for the best and fingers crossed. It's excellent presentation, Marian, as always.
We go on to our last speaker, Dr. Anusuya, who's going to be telling us when to cut, when to watch, and surgical decisions in orbital disease. Look forward to, we always say we keep the best for the last. So let's hear from you, Anusuya.
Yeah, is my screen, oh, just a minute. Yeah, is my screen visible, madam?
Yes, yes.
So at the outset, I would like to thank I Foundation and Dr. Chitra for this opportunity. And I will also like to congratulate both you and Lakshmi for choosing this fantastic topic. I really liked making this presentation because this is such a nuanced and interesting topic to speak on. So I will be talking on when to cut and when to watch surgical decision making in orbital inflammation. Yeah, so this will be the flow of my presentation. I will give some brief overview on orbital inflammation. Dr. Marian has made my job pretty easy. I will also talk about the location-wise classification, and then straight away I will move on to the question that when do we observe and when do we biopsy orbital inflammatory lesion. So orbital inflammation, it is basically a combination of all these inflammatory sign in an orbit, a proptose, painful red eye with reduced ocular motility with or without decreased vision. So it is usually a disease of fourth to sixth decade. Majority, around 90% are unilateral. They are acute in onset, painful, proptosis, lipedema, chemosis, a combination of these, and there is dramatic resolution on steroid. Dramatic is the word that all of us have been taught ever since our MBBS days. And imaging is typical of the most common ones, the dacryoadenitis and myositis. So we need to remember that it is painful and there is a dramatic resolution on steroids and unilateral. So having understood that, I will just be talking about the location-wise classification, which was in this landmark paper by Rootman. It was nicely elucidated. So most commonly what we see are is dacryoadenitis, but we need to understand it can affect anything and everything within the orbit. So it can be a myositis, it can be a diffuse orbital involvement, it can be an anterior orbital involvement or a posterior apical involvement, perineuritis, or just a focal mass, which is very rare. And it can also be a combination of any of these sites. We need to understand a major concern for all of us here are the recurrences which happen for an orbital inflammatory disease. Majorly talking about the non-specific orbital inflammation, which is a disease of exclusion, as Dr. Marian pointed. So you essentially rule out the specific causes, but with evolving literature, like this is a shrinking terminology, the non-specific orbital inflammation, because the specific diseases are being discovered, like a recent one being IgG4 related disease. So recurrence is a major concern, and recurrence can also be in a different location is what we need to understand. Now, when do we observe? When it is a typical presentation. So for that, we need to understand what are the typical presentations. I will be taking you through a series of cases elucidating the typical presentations. The most common presentation of a dacryoadenitis in a young male with a S-shaped eyelid swelling with pain, and you can see the palpebral lobe thickening there. On a CT scan orbit, you can see the thickened lacrimal gland, which is also causing a displacement of the globe down and medially. So this is a anterior variant of the or non-specific orbital inflammation. You see eyelid edema, uveitis, and chemosis. On scanning, you might as well see some swelling at the insertion of the muscle, but majorly the orbit looks normal. But what was notable in this patient was the other eye has a dacryoadenitis. So as I said, a combination of sites can be there for a particular patient. So the same patient on steroids. So this gentleman presented with this myositis, the first attack involving the right lateral rectus muscle. You can see a fusiform thickening of the muscle, but what is noteworthy here is that the tendon is involved, vis-a-vis a case of thyroid eye disease where there is no pain and it is usually tendon sparing. So here it is a tendon involving muscle involvement and pain is there. So the same patient having the second attack where the left eye medial rectus is involved, the same being confirmed on a orbital mode of B scan. The third attack where the abduction motility limitation is there for involvement of the medial rectus muscle. Moving on to the next type, the apical type, it can just involve the apex and have an intracranial extension as well. These cases, majorly we go ahead and do a biopsy to establish the diagnosis. A diffuse infiltration of the orbit, you can see the entire orbit is involved here. This patient required an exenteration. Focal mass, very rare, but we do encounter, like here, this patient has an intraconal mass. we do encounter non-specific orbital inflammation presenting as a orbital focal mass. Perineuritis, this patient has a combination of anterior uveitis. The entire uveoscleral complex is thickened, as you can see here, along with the involvement of the nerve. So the same patient, you can see the optic nerve has a papillitis here, and the sclerocoroidal coats are thickened. Pediatric NSOI, a word of caution there, it is little different from the adult NSOIs because, as I said, the adult NSOIs are predominantly unilateral in 90% cases, but here bilaterality is more common. 40% patients are bilateral, and there can be systemic associations like JIA, sarcoidosis, and uveitis is common in pediatric age group and not so common in adult, and the chances of recurrence and relapses are more in pediatric. So these are the differences with adult NSY. So having understood that, when do we observe, coming back to the question in hand, that whenever we see this classic clinical picture of orbital inflammation, pain, dramatic response to steroid, the typical radiology showing myositis with tendon involvement or dacryoadenitis, we observe the patient, start the patient on steroid and observe. So when do we consider biopsy? So I will again divide this into clinical red flags and imaging red flags. So clinical red flag, the 60-year-old gentleman, he has a superior orbital mass, but there is no pain. So absence of pain, and the mass is there since the past 6 months, which is again contradicting to orbital inflammation. Orbital inflammation will always be an acute cause. So absence of pain or an indolent course, whenever you see, go ahead and do a biopsy. So this was a case of orbital lymphoma, the most common differential for a orbital inflammatory lesion. Again, this young lady came to us in 2018. You can see there is a superior orbital mass, and this is we had started her on IVMP. She lost to follow up, only to return after 2 years in 2021. She said that she has continued on steroid, had taken multiple intravenous methylprednisolone at locally, but see what has happened. So there is definite progression that you see. The mass is now involving the entire orbit. So progression or suboptimal response. In short, a patient refractory to steroid therapy, you will have to go in and do a biopsy. Moving on to the same patient which I showed earlier, myositis, whenever there are multiple recurrences, it's a good idea to go ahead, establish the diagnosis and treat the patient. A pediatric patient with bilaterality. So in my practice, I have a very low threshold for doing biopsy, majorly in these patients who are bilateral. Even if they have the typical symptoms of pain, this is because of the advent of this entity. This is again one of our patients which we had reported, IgG4 related orbital inflammation. What we need to realize is we need to establish the diagnosis. If we see the WHO diagnostic protocol, histopathology is a must to establish the diagnosis, and systemic associations are as common as 80%. So we can't afford to miss IgG4 related orbital inflammation. Major things like autoimmune pancreatitis, sclerosing cholangitis, retroperitoneal and mediastinal fibrosis. Even a March lymphoma means this can subsequently lead to an orbital lymphoma, is also a possibility. So in bilateral cases, our threshold for doing a biopsy should be much lower. Pediatric NSY or an NSY, any extremes of age, it's better to do a biopsy and then go ahead with treatment. So what are the imaging red flags? So this particular patient, a 51-year-old gentleman, was diagnosed as orbital inflammation by his treating ophthalmologist, and a tarsorrhaphy, as you can see, was done, and the patient was started on IVMP. But what do we see here? This is the imaging, and we see a disproportionate, I agree that it is a tendon involving extraocular muscle thickening. but it is bilateral in an adult male. It is disproportionately massive and it is non-fusiform. It majorly involves the insertion. So that should have been a red flag. However, this was missed, and only the patient presented to us after a few days with a lot of inflammation, both the eyes, and it was no PL bilaterally. So then we went ahead and performed the biopsy, and this is the bone marrow biopsy where we see a lot of plasma cells, and on staining they were positive for IgG light chains, which is indicative of multiple myeloma, orbital involvement in multiple myeloma, or what we call as plasmacytoma. So but we need to differentiate this from a typical myositis, which is fusiform. Though it may involve the insertion, it is not so disproportionately massive and as in this case. Moving on to the next patient, a 43-year-old male, again treated elsewhere as orbital inflammation with IVMP. But what do we, without a scan? So when the patient came to us, we performed the scan, and what do we see here? We see bone erosion and a triradiate mass there. So bone erosion again is a red flag. Triradiate mass is not common for orbital inflammations. So this was a case of orbital metastasis from a prostate carcinoma. So whenever you see, again, vis-a-vis this particular gentleman, this girl, you can see a sino-orbital mass there. But what is striking is the bone erosion. So bone erosion, sino-orbital mass, again, is not a common presentation for NSY. So we went ahead, performed a biopsy, but this was a variant of the commonly seen NSY, and this was a sclerosing NSY, which I was talking to you earlier. These are extremely resistant to the common treatment that we have in our armamentarium. So again, a biopsy will help us explain the prognosis in a much better way to the patient. So whenever the mass is infiltrative, like it is involving everything is infiltrated, it is best to go ahead and establish the diagnosis before going on and charging the patient with IVMP. Again, this the same gentleman that I showed earlier, painless superior orbital mass, and you see the typical molding around the globe. So lymphoma being just blood cells, they just find their way around whatever is there. So you see the mass is molding around the globe. Molding around the globe is a typical sign of lymphoma and not NSY. So whenever it is there, go ahead, perform a biopsy, rule out lymphoma, and then go ahead and charge the patient with IVMP. Because with steroid, lymphomas will also respond, but it will recur in the future. Thus, to conclude, a typical clinical scenario like this with S-shaped lead edema, localized tenderness of the lacrimal gland, typical radiology suggesting dacroadenitis, myositis, go ahead, treat the patient with steroid, dramatic response to steroid. You can be pretty sure that you are dealing with a orbital inflammation. However, we should perform biopsy whenever we see any of this clinical or imaging red flags. Clinical atypical presentation, painless, bilateral, indolent course, recurrent, refractory on steroid, extremes of age. On imaging, whenever we see bone erosion, infiltrative lesion, massive non-fusiform extraocular muscle thickening, molding around the globe, or when it is an approachable site to establish any granulomatous or other systemic disease like vaginous granulomatosis or sarcoidosis. So thank you everyone for a patient listening.
Thank you. Thank you very much, Anusuya, for a wonderful talk. And Vidya, let's take one more question before we conclude. It's been an amazing webinar. Each of you excelling the other.
Yes. Yes, madam. Anusa answered all my questions that I had in mind about the pediatric IOD and other cases. But just a query regarding, we had recently a patient who just presented with ptosis alone with recurrent edema. While on tapering steroid, she will again recur with ptosis. So do you see a role for intralesional steroids in this case, or should we be starting a steroid sparing agents for these kind of patients where just recurring on tapering doses of steroids?
Yeah, Vidya, so ptosis, did you do an imaging for this patient? Was there
Yes, we had an imaging.
myositis?
It was suggestive of an inflammatory lesion involving the LPS and SR complex, but there was no mass lesion, and the ptosis completely disappears on starting steroids. Lakshmi might be able to give a better picture because she
Yeah,
was treating the patient.
so yeah, Dr. Anuswa, so the patient is a 20-year-old girl who's come with a 6-month history of ptosis, almost complete ptosis, and on imaging there is enhancement of the SR, LPS and the lacrimal gland area. So we started on steroids. When she reached around 15 mg of steroid, 20 or 10 mg steroids, again the ptosis developed. So I was thinking the next step we could do is I thought it is a variant of NSOID only. So I was thinking next step we could do an intralesional steroid injection. So that was the doubt. Should we do an injection or should we start with steroid sparing agent?
Yeah, so but a slow taper will be a good idea. Lakshmi can try with a slow stay taper. If that is also not working, go ahead and repeat a imaging, and based on the amount of residual disease, you can take a call. If you see there is a lot of SRLPS edema still persistent, then you can consider intralesional steroid. But a word of caution: these like many a time, this ptosis takes a lot of time to go back to normal. It may take as long as 4 to 6 months. For also our patients of orbital cellulitis, we see that happening. So there's some residual swelling there. So it will be a good idea to wait, repeat a scan, and then go in.
Okay.
And without cysticercosis, a ruptured cyst.
Yes, so I thought of that, but the she had a CT and MRI, Dr. TVD. She didn't have a cyst. I think I'll again request another one and see if there's a cyst. True. Yeah.
So, anything else? Dr. Vikas, Dr. Rashmi, before we conclude?
Very nice session, ma'am. Thank you so much for organizing this. Learned quite a few new things also. Yeah. Thank you.
Yes, I'd like to add my thanks to you and the organizing team, Dr. Vidya, Dr. Lakshmi. This was an excellent idea. It was a very, very informative session.
Very
And
nice. And
I want to express my appreciation of the speakers.
yeah, the
I
speakers were just
really enjoyed
amazing.
your talks, all of you.
Yeah, each talk, one to beat the other, and the discussions. And I'm sure, I hope many of the youngsters, if they watch, there's a lot they're going to learn because so much of experience talking all the time. So thanks a lot for being here, sparing this evening to be with us. Thank you so much. Thank you.
Thank you, ma'am. Thank you so much.
Thank you.
Bye.
Thank you, everyone.
Everyone, have a fantastic evening.
Thank you.
Yeah.
Thank you.
Happy Diwali to all of you. Thank you.
Okay.
Same to
Oh,
you.
yes. Happy
Thank
Diwali
you.
to all.
Happy Diwali. Bye.
Bye-bye.
Thank you, Vidya. Thank you, Dr. Shankar.
Thank you.
Bye.
Bye, DVD.
Bye.